Hi. The topic given to me was IMbrave 150, and it's basically the use of Atezolizumab and Bevacizumab in the first line hepatocellular cancer. And I understand it's a genitourinary conference, but then it's a Roche-sponsored session, and the slides have been provided by the Roche. And I am rather privileged to speak about this, drug doublet, because I think it's the most exciting era when it comes to the IO or immune checkpoint inhibitors, and especially in the hepatocellular cancer when we have, it was more of a considered as a recalcitrant disease, and now we have this exciting data with Atezo-Bev, and I think I'll share a little more about it. What is the rationale of combining Atezo and Bev? I think we all understand that more and more of malignancies, especially the hepatocellular cancer, it is there's obviously a lot of immune suppression involved in it. The moment there is a cancer antigen release, then cancer antigens are being picked up by the dendritic cells, and they are further presented to the T cells, and the T cells traffic them to the T cells traffic to the tumor, and then that's why they cause the destruction of the tumor. So why and how this came through was that it was observed that there was a spontaneous regression of the tumors in the hepatocellular, which possibly was carried out by the immune system. And it was also seen that the tumor infiltrating T cells were found in more than 50% of the HCC patients. And that's where this hypothesis that, if you could give immune checkpoint inhibitors should help in the HCC. And then the combination of Atezo-Bev was made. And I think there's a rationale behind it, because what it has been seen that bevacizumab is, it promotes dendritic cell maturation. It also normalizes the T cell, or it normalizes the tumor vasculature, thus helping, the increased infiltration of the T cells, increased infiltration of the T cells. And then there is there is decreased activity of the immune suppressive by the bevacizumab. And as we all know, atezolizumab is a PD-L1 inhibitor, and it helps in it allows the T cells to act a little more than what it would normally have. So that was the biochemical, or that was the molecular rationale. Now this is the clinical rationale. So there was a phase 1-2 trial in which Atezo-Bev was studied as single arm, and then there was phase 1B kind of arm in which Atezo-Bev was compared with Atezo mono. There was Atezo-Bev arm and there was a Atezo mono arm, and there's a good amount of substantial data in Atezo monotherapy, and that's what gave origin to the randomized phase 3 trial of IMbrave 150. In the IMbrave 150, there were two arms, Atezo-Bev compared with the standard of care, the sorafenib at that time. So the patients, it was a well-designed trial, and the eligibility was that the patients had to be locally advanced and metastatic unresectable HCC, which most of us see. They should not have received any prior therapy, and it was a multi-center trial. Was present that centers are present all over the world. The subset analysis was macrovascular invasion and extrahepatic spread, and the baseline AFP were divided into less than 400 or more than 400. And the patients were randomized 2:1, with the Atezo being 200 milligram 3 weekly, and bevacizumab 15 milligram per kg 3 weekly, and sorafenib 400 mg BD. So to be very frank, I don't think any one of us generally are able to give sorafenib 200 mg BD, and I think more and more of our clinical practice has moved towards lenvatinib, 8 mg and 12 mg. And to be fair, I don't think we are able to give 15 Bev 15 also. However, in a significant number of patients, we are able to escalate to that dose. And the endpoints were that the primary endpoints were the PFS, and the co-primary endpoint was overall survival. So now the IMbrave 150, the baseline characteristics were well matched in both the arms. And if you could see that there was a significant number of patients who had viral hepatitis, be it HBV and HPV-C, and there were enough patients. There were 30 patients with non-viral hepatitis, and another around 50% of the patients had received prior local therapy for HCC. So the efficacy results were that at the end of 6 months, the overall survival difference was around 13%. The 6-month OS rate was 85%, with 72% with sorafenib. And in the first analysis, the median OS was not reached, but in the follow-up study, it was I'll, yeah, I'll just come to that in a, yeah. So in a follow-up study, updated analysis, the median OS was 19.2 months with 13.4 months with the standard of care arm, which gave us a almost 34% relative benefit, or the hazard was 0.66, and the 18-month overall difference was around 8%. Again, the co-primary endpoints were the 6 months PFS rate was 55 versus 37%, with a hazard of 0.59. And its Atezolizumab demonstrated clinically meaningful and statistically significant reduction in the disease and the risk of disease progression or death. The updated analysis by the independent review committee was that at the end of around a year, there was almost a 14% difference in the progression-free survival. And I think if you could look at it, almost 1/4 of the patients were progression-free at the end of 1.5 years. And that is something remarkable, because I think most of us struggle with hepatocellular cancer. Even in lenvatinib era, we generally have patients doing well for 6 months, 8 months, max 10 months, and then they tend to progress. And Atezolizumab, almost 1/4, that is 24% of the patients were PFS free. The China cohort updated OS was even better, with the 18-month overall survival of 56% versus 33% with the standard of care arm, with a hazard of 0.53. And if it was seen that the subgroups other than the BCLC stage B, which I think that is in which the standard of care of sorafenib was better. Other than that, almost all the subgroup analysis had shown that Atezolizumab is better, and I think we have also seen it in the clinical practice that Atezolizumab it's amazingly well tolerated, and you just need to find the right patient for it. That's it. And again, the PFS benefit was also present in consistent across all the subgroups. And what was seen was that if you look at the overall response rates, whereas you saw only 12% response rates in the sorafenib arm, it was almost 27%. And once you looked at the updated analysis, what you saw was that the confirmed overall response rate was almost 30, or rather, the CR was present in almost 8% patients. The PR was there in 22% of the patients, and I think that's a very good. If somebody could tell me that you would have a CR of around 8%, while other than that, if you look at the standard of care arm, it was less than 1%, or it was 1% in 1% CR. I think that's remarkable. And the PR was around 22% in 72 patients, as compared to 17 patients or 11% in the standard of care arm. And the median duration of response was around 18 months, as compared to around 15 months. And as we understand, immunotherapy is not about the first; it was also about the second PFS also. And I think that's where the absolute advantage also lies. So as compared to the safety, I think most of my experience has been pretty safe as yet, and touch wood for that. I think it's about the right patient selection, and there are hardly any significant toxicities in clinical practice. However, we need to be aware about it. So the all grade toxicity was there, but then most of it was grade 1 and grade 2 toxicity. I think I'll just move to the next slide, because this is where we looked at the individual toxicity. So the toxicities which were of a concern was there's obviously a risk of hemorrhage. And then there is risk of epistaxis, hypothyroidism, hypertension, and Atezolizumab. However, the proteinuria is it's also present in the sorafenib arm. And as we all understand that the tolerance of sorafenib is very difficult, and palmoparental erythrodysesthesia is something which is a huge concern in sorafenib, and most of our patients have the problem. And similar is the problem with diarrhea. So I think those were obviously higher in the sorafenib arm. And so if you look at it, so proteinuria, infusion-related reactions, pruritus, fever, epistaxis. So in my clinical practice, what I've seen is hypertension is obviously a bit of concern, and hypothyroidism is because of the immunotherapy. And yes, a bit of fatigue and musculoskeletal pain does happen. And I don't think I've been using sorafenib in the recent practice. If there is a problem, I end up using lenvatinib, and which obviously the problem is with the hypertension and a bit of fatigue. Again, looking at the grade 3-4 adverse effects, hypertension, altered LFTs, Proteinuria is what it is. And I think we all are well aware of the grade 3, grade 4 side effects of sorafenib. Now, looking at the grade 3, grade 5, or the most severest of the adverse effects. Yes, I think we all are scared of giving Atezolizumab because of the GI hemorrhage. And to be very frank and fair, that's what I have not had out of the 4-5 patients I have given Atezolizumab till now. And however, in the trial also 3 patients had grade 5 GI hemorrhage. That makes up 0.9% or 1% of it. And I think other, which is a little more risky, is obviously the gastric ulcer perforation, multi-organ dysfunction, esophageal varices hemorrhage. So all these are known side effects, and I think the patient should be rightfully counseled about it. But I think if you could just have this slide and the next slide. So the bleeding hemorrhage risk, all grades is almost similar in both the arms. And if you look at the grade 3, grade 4, it's almost similar. So if you look at the GI bleeding part of it, a comparable portion of patients in sorafenib Atezolizumab arm experience events under the, they almost had the same bleeding events. And the incidence of upper GI bleeding and esophageal varices were consistent with that of Bev monotherapy. So as you would choose it for Bev, so would you choose it for Atezolizumab also, was the message given out. And I'll come to this slide a bit later. This is the slide which I would want to focus on. If you look at the REFLECT trial versus IMbrave trial, the key exclusion criteria in the REFLECT trial were the patient who had esophageal gastric varices that required treatment were excluded from the REFLECT trial. And so if you look at the IMbrave 150, the patients who were excluded, obviously we're talking about Child-Cook A6 and A5 and A6 patients. The only patients who were excluded were untreated or incompletely treated with esophageal gastric varices with bleeding or at high risk of bleeding. So whenever we are choosing patients for Atezolizumab, what we need to make sure is they do not have varices who have high risk of bleeding. And if they have certain varices, they should be treated completely. I think that's about it. And I think then they can be included in the study or in the treatment arm after that. And if you look at the median duration of treatment, obviously it's higher in the Atezolizumab arm. And all grade high bleeding were almost similar in both the trials, with the lenvatinib as well as Atezolizumab. And now coming to some typical difference in the safety profile between the TKIs and Atezolizumab. So what was seen was the diarrhea are obviously lesser. It was the hypertension and the asthenia and the proteinuria which was higher in the Atezolizumab arm, and it was diarrheas which were higher in the sorafenib arm, and obviously the palmoplantar erythrodysplasias. So bleeding events with the systemic therapies were typically low in grade and unrelated to the varices is what was the message out, and I think that's been my observation also. So Atezolizumab, yes, it did have higher epistaxis, but if you looked at the GI bleeding, it was it was almost similar between the sorafenib and Atezolizumab arm. Hepatitis, again, I have not encountered it as yet, but then some grade of hepatitis is known. And I think it's that slight elevation in the transaminases. And then for however, grade 3, grade 4 were not that severe. Coming to the quality of life assessment, the questionnaire was given and finished by almost 93% of the patient until cycle 17 and more than 80% thereafter. So all of us who have given sorafenib, finishing it now, 1 minute. Yeah, finishing it off. So all of who has given sorafenib, we all understand that sorafenib just, it's a poor drug to tolerate. So that was what was visible also. It deteriorates the quality of life. And that's what it was clear through the trial. And now anyway, the standard of care has become Atezolizumab. And in a person who was treated before this, there's a clear recommendation that, there's a clear understanding that if somebody has not been approved, somebody has not been given Atezolizumab to begin with, should be treated with Atezolizumab. So conclusion are there is a combination of Atezolizumab has demonstrated increased efficacy, and it should be the standard of care moving forward. Thank you.